In this video, we are going to discuss the use of anti-VEGF therapy in cases of retinal vein occlusion. I would like to acknowledge the help of my colleague Muhammad Ashraf al-Masri and my other younger collaborators in achieving this presentation. The first type of vein occlusion is a branch retinal vein occlusion, which usually complicates by central macular edema. In light of randomized clinical trials, we are going to explain how we use anti-VEGF injections in the eye in order to control the complications of venous occlusion. The first trial is the BRVO trial, in which we had 397 patients of BRVO. They were grouped into 3 arms. Sham group did not receive injections in the first 6 months, and the 2 other arms received 2 doses of ranibizumab. The sham group received injections after 6 months to join the 2 other arms in their treatment. All cases were given a PRN protocol in the second 6 months of the trial. The next trial was Horizon, which is the second year of patients included in BRVO. These cases were all followed up and given a PRN protocol of ranibizumab injection in the second year. As you can see in these curves, the visual acuity showed improvement in the first year, rapidly in the arms who received intravitreal injection of ranibizumab, and later in the second half of the first year in cases who were treated by sham in the first 6 months. You can see that the second 6 months of the group of receiving no treatment, they showed an improvement in vision in the second 6 months of the first year. However, the cases who received injections from the start showed an early improvement in visual acuity. This improvement was maintained towards the end of the first year by maintaining a PRN protocol for these patients. The sham group showed improvement a bit less than the cases who received injections earlier on in the first year. However, they still showed improvement in the first year of the trial. As you can see, the second part of the trial is Horizon, where patients were followed up in the second year and given injections as needed according to the need and the change in macular edema by OCT. The visual acuity gained by injections in the first year was maintained towards the end of the trial. Even the cases who started as a sham, receiving no treatment the first 6 months of BRVO, showed improvement in visual acuity, reaching the level of visual acuity gained by all groups in the end of the second year. You can see how the anatomy shows a difference. Early on, you can see that there is a decrease in the central macular thickness in cases who received injections. By the 6 months when the injection started in the sham group, again improvement in the anatomy was seen to become similar anatomically to the other 2 arms receiving ranibizumab. By the end of the first year, they were similar in anatomy, and this was maintained by a PRN protocol in the second year, the Horizon part of the study. In order to see if the PRN protocol was valid enough, or maybe a monthly injections, meaning more injections, would give us a better visual gain, the SHORE study tried to see the difference between a PRN protocol and a monthly protocol. You can see that the highest visual gain in branch retinal vein occlusion cases was seen in the PRN cases even after 1 year and 3 months by the end of the study. So, we know that using a PRN protocol upon recurrence on OCT works, and it does not lead to any loss of the visual gain that was gained at the beginning of injections and the early response. All patients actually receiving the injections improve in visual acuity. Laser grid and using it instead of injections before instilling your injections, as in the sham group, does not prevent improvement afterwards if you start injecting later on in the course of the disease. So, how about adding laser in the era of anti-VEGF, meaning you can give some macular laser in order to improve the edema. The brighter study tried to see the effect of adding laser to injections or even using laser alone, and how would this fare in branch retinal vein occlusion cases with macular edema. They started with 3 monthly loading doses followed by a PRN regimen as before, and laser was being given to one arm of these patients, both arms receiving ranibizumab, and another arm received only laser without injections. The average number of injections in this study showed no difference when you add laser to the injections, so we know that adding laser does not reduce the number of injections on average in the first year. Also, the visual acuity gain was what we know for sure is that both arms receiving injections with laser or without are much better than receiving laser alone. So let's compare the group of receiving laser alone to the other two groups. You can see that the medium visual acuity patients showed less visual acuity gain. Even worse, the high visual acuity patients at the start of the study showed some worsening using laser alone. So this shows that the injections are superior, especially with higher visual acuity. Visual acuity gain comparing to the ischemia present in these cases. Well, you can see that ischemic cases showed some improvement. Non-ischemic cases did not benefit from laser. They were actually the worst to improve. See that 9 letters improvement in ischemic cases was there, compared to only 2 letters in cases who showed no ischemia. So it is not favored to add laser in cases of non-ischemia. If we compare the duration of retinal vein occlusion before the initiation of treatment, you can see that we had only 5 letter gains in cases who weren't that chronic, under 12 months of duration. However, chronic cases showed a bit better improvement, which was not far from the improvement in the injection groups alone. Adding both together, the laser and the injections in chronic cases showed some improvement above using injections alone. So, we would recommend using a PRN protocol in all cases, and it does not lead to any loss of visual gain in comparison to monthly injections. All patients receiving injections usually improve, and laser grid does not prevent the improvement if you start injections later in the course of the disease. You avoid laser in high visual acuity patients and non-ischemic patients, the better ones in general, and it is only beneficial when you have a chronic branch vein occlusion. RETAIN is the study looking at the long-term follow-up of these patients. It goes to a total of 4 years of follow-up, all using a PRN protocol, and we analyze patients accordingly. You can see here 6-month blocks of treatment, and you can see that the visual acuity gained by the first year was maintained through the period of 4 years, and the foveal thickness, which was improved by injections in the first 6 months, was also maintained to a good level of thickness by the end of 4 years. So this is a good long-term treatment for macular edema of branch vein. Also, the number of injections showed significant reductions over the years, going to 1 injection every 6 months on average by the end of 4 years. Actually, starting from the second year, we had an average of 1 to 2 injections every 6 months. If we divide these patients into early good responders versus the early not so good responders and see how they fare over the 4 years study period, we can see that both arms are generally okay, showing relatively good foveal thickness and definitely good visual acuity gain. However, it's only the difference in the number of injections which is expected. As you can see, by the end of 4 years, the good responders at the start of the study showed minimal injections on average by the end of the 4th year. However, the patients who did not show this very good response at the beginning of the study still needed on average 1 to 2 injections every 6 months, even after 4 years. So they only needed more injections, however, they maintained good visual acuity gain. We know that 50% of these cases had resolution of the edema, and there was no intraretinal fluid, even without injection, for 6 months. Visual acuity was achieved in 80% of cases at the level of 20/40, which is very good. The other 50% still showed good visual acuity improvement, however, still required an average of 3 injections in the last year by the 4th. So, we do say that, of course, branch retinal vein occlusion shows a good prognosis. You should avoid laser in high visual acuity and non-ischemic patients. It's only beneficial in chronic cases over 12-month duration before the initiation of treatment. The PRN protocol is definitely good enough to maintain visual gains over the year. Even cases who didn't show early good anatomical response showed visual gain by the end of 4 years and still maintained. This is different in comparison to central vein occlusion. In the case of central retinal vein occlusion, we have different studies to describe how the treatment will go. The CRUISE study, in comparison to BRVO, recruited 392 patients, and again we had the sham group and 2 doses of ranibizumab. And again, after 6 months, the sham group received injections PRN according to the edema found in OCT. The horizon, the second part of study in the second year of these patients, showed how would they fare on the follow-up in the second year using a PRN protocol, injecting on recurrence in case of edema. And they had similar results as regards early good response in visual gain, maintained through the end of the first year, also maintained in the second year by a PRN protocol. At the 6-month point, the sham group received injections, showing improvement, less than starting early injections. However, was maintained and improving in the second year to be very close to one of the doses of the ranibizumab. So, again, even if you start late in the treatment, you can still have a good visual acuity gain. The reduction in the edema of the retina was seen very early in the injection groups and delayed to the 6-month point, where again injecting at this point showed the improvement even in the sham group who did not start the injections early on. The SHORE study to describe how would PRN protocol would do in comparison to a monthly protocol again showed very good response and maybe the best outcome in a PRN protocol. So we do not need monthly injections. The RETAIN study, which would again look at the 4 years follow-up of these patients on a PRN protocol, showed maintenance of the visual gain in the first 6 months, maintained by a PRN protocol to the end of 4 years, with of course a simultaneous improvement in the central foveal thickness over the 4 years. However, the number of injections was a bit more. You can see that the early injection area of 12 months showed an average of 8 injections, ending up in around 3 injections in the 4th year. Comparing better responders in the early phases in comparison to the less responsive who still showed edema in the first 6 months and the end of the first year, comparing them both showed that still they needed lots of injections in order to maintain the visual gain and the anatomy by the end of the 4 years. It is clearly shown here that the difference between early resolved edema and the unresolved edema in the first 6 months showed marked difference in the number of injections in the 4th year. Nearly no injection was needed in cases who showed early resolution in the first 3 to 6 months. However, the group with some edema always there and needing more injections maintained this need for more injections in the last year averaging 6 injections per year in the 4th year. However, most of the cases showed improvement, with 44% total resolution of the edema and excellent vision, 78% gained 15 letters, and the final visual acuity of 20/40 or better was in 2/3 of patients. 56% of patients still required these injections by the end of the 4th year, and of course less than the visual gain obtained in good responders. However, still considerable visual gain was there. The 3-monthly doses to assess early responders and to compare them to incomplete responders are mandatory. At that point, you can say that good responders having dry macula would have less and less injections over the years, and you can tell your patients that he will do very well over the period of 4 years. PRN protocols works best and works even similar to a monthly injection. You do not need a treat and extend protocol or additional injections, no need for laser in cases of non-ischemia, and the end result is usually good if you maintain your PRN protocol. The RELATE study was looking for the increase in the dose given, meaning more than 0.5 milligrams of ranibizumab, and it was even more than doubling the dose. It was given as 2 milligrams, 4 times the regular dose, in a similar volume of 0.05 milliliter injection. This showed no improvement in visual acuity over the regular dose and no decrease in the injection numbers. The next question was answered in the WAVE study, where additional PRP in ischemic cases might reduce the number of injections or improve visual gain. However, in this randomized trial, the gain and the number of injections were similar. So adding PRP given if the periphery is ischemic at around 4 months after diagnosis did not give any additional benefit. It is of no use up till now. Thank you very much for listening, and I hope that this concludes your RVO protocol.